Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great, I have no conflicts. Thanks. Brian asked me to revisit the same-day start antiretroviral issue and sort of get a discussion going about what's going on around the echo community and what people are doing in practice, and sort of revisit some of the data that led to this practice and where we are today. So I'm going to start with a case and then a polling question, and then we can go from there. A 30-year-old man presents from STD clinic with a new diagnosis of HIV to your practice. He's got a HIV-1 antibody that's positive, a P24 antigen that's positive, and an RNA that's about 10,000 copies. He was just told that he has HIV this morning, and he's asymptomatic, but was tested because he had condomless sex with multiple male partners in the last year, and he denies any recent history of an acute illness. He is housed, denies any other medical problems. So, would you start ART today? All right, well, that's good to know. I want to know for the people that theoretically would want to do it but are not doing it, what are some of the barriers to or concerns you have about same-day initiation? Is it mainly obtaining insurance coverage, lack of time for counseling, intake, medication discussion, insufficient staffing, or other? Okay, so it looks like it's a number of different issues, probably a combination of issues. I wanted to revisit what it's actually in the guidelines and, what is standard of care. Should we be offering same-day start as standard of care? So the HHS HIV Treatment Guidelines actually obviously state that everyone should be started on ART and that therapy should be initiated as soon as possible. But there's not really in the main guidelines much about same-day start. And I'll go through what the paragraph that they have on ART same-day start initiation is at the end after I review the data. So we'll talk about the pros and cons to starting the same day, but first I want to show you kind of the rationale and background for why this would be a good idea. We know that particularly in resource-limited settings, where they've shown this the most, is that the loss to follow-up is high between testing and ART initiation. And there are data in the US as well about this, that if we go a longer period of time from the test being positive to starting therapy, there's a risk of losing patients to follow-up and not being able to re-engage them. And then we also worry from a population level that there's an increased risk of transmission to others if they're not on ART. So treatment as prevention, so getting people on treatment as soon as possible is really important. And then potential for higher mortality if patients are delayed start. So this is really, again, waiting till people are very advanced with HIV. We're not talking, and when we're talking about same-day start versus soon start, we're not talking about waiting until people are sick, obviously. We're not waiting for CD4 counts to decline. So is there really such a push to start the exact same day that you see that patient for the first time? So there are two big studies in Sub-Saharan, in resource-limited settings, one in Sub-Saharan Africa and one in Haiti that I'll review. These are actually the only two big studies to date. These were the same studies that I presented 2 years ago when I talked about this topic. So let me just review them. The first study is called RAPID, and it's a randomized controlled trial of initiating HIV therapy as the first clinic visit versus standard procedures. And so standard initiation procedures are really to obtain blood work, do counseling, group and individual counseling, and really not dispensing meds until visit 6. So again, a pretty, not necessarily reflective of what we do here, waiting 6 visits to start treatment, versus the rapid initiation, which is you do all of those things essentially at one visit, including dispensing ART. So randomized, so close to 200 people in each arm for standard versus rapid initiation on day 1. And these are the results. So what it showed is that in the standard arm in red, there was a longer time to lower percentage of people initiating ART in the study enrollment period, which was 200 days. So if you didn't start that same day, you had a less likelihood of starting over that entire period of time. So that was pretty remarkable results. So offering single visit ART initiation in South Africa in this study increased uptake of ART by 36% and viral suppression by 26%. So pretty remarkable findings. But again, I put the caveat that we, as standard of practice here, don't wait 6 visits and do all of that counseling and separate visits for all of those things to initiate patients. So may not be completely applicable in our setting. So similarly, there was a protocol for same-day ART start in Haiti, where the same-day start did adherence counseling at the first visit. They had a social worker visit, a physician visit, and they started ART versus doing multiple visits over a period of time for ART initiation. And mostly people didn't start ART until day 21, which was 3 weeks after they were seen for their initial visit. So what did they show in Haiti? And this is retention in care, so looking not at virologic suppression, but retention in care. And for people who had same-day ART compared to starting ART at day 21 in this study, there was a higher percentage of people who were retained for starting same day. So these 2 studies are international studies, not U.S. studies. So I wanted to move to the U.S. studies in a minute. But what they said is same-day ART testing and initiation is feasible, beneficial, and improves retention and virologic suppression. So qualitatively, what they noted is that people felt like the HIV diagnosis was a really traumatic experience, and getting those meds the same day increased hope and connection to care. The barriers, obviously, that if you had multiple visits to get your ART, is that there's more time, more transportation, and more costs overall to the healthcare system by making them come back multiple visits. So based on these 2 studies, the WHO guidelines suggested that rapid, within 7 days, so not same day, ART initiation should be offered to everyone with HIV following a clinical assessment. ART should be offered on same day for those ready to start, and the goal to improve linkage to care and reduce loss to follow-up. So where are we in the U.S.? And I'll just put that in there for what a clinical assessment means in terms of WHO, is the San Francisco rapid ART start. So these are the only data that we have for U.S. same-day start. And I'll show the initial pilot study and the updated real-world experience that they've had. So same-day or next appointment for newly diagnosed patients. They meet with a provider, an RN, social worker, financial advocate. They have labs drawn, meds are given, and often in a starter pack. There's close follow-up within 1 week, and then they transition from their rapid ART start clinic to their PCP. So they wanted to highlight that these are not really the easiest patients they could find to do this. 25% had acute HIV. Nearly half of them had a major mental health issue and also had illicit substance use, and then 28% were homeless. So this was not by no means this cherry picking who would be the best person to start on the same day. And what they really showed is that essentially people who got their ART right away suppressed more quickly, which is not shocking. They got on meds and they suppressed more quickly, as opposed to waiting for their standard procedures in terms of months to ART, weeks to ART potentially. So time to virologic suppression in this pilot study was 56 days. So their argument from a population level is that the sooner that we get the people that are positive on treatment, the less likely they are to infect others, and it overall improves their health as well, and their retention is care, as shown by other studies. So what do we have so far? So just recently there was an update to their rapid ART start experience. So after their pilot, they actually instituted same-day start for all newly diagnosed patients, and that became their standard of care. So they felt like these were really powerful results of their pilot, and that we should be doing that for everyone. So 225 patients were referred for the rapid ART from testing that was done in the community and STD clinics from 2013 to 2017. And 96% of those patients were started immediately on ART, meaning that same day or the following day. By 1 year after intake, over 95% of them achieved virologic suppression to less than 200 copies, which was great, 1 year follow-up success. They did show that there was a nearly 15% of them had virologic rebound at roughly around medium follow-up of 1 year. But most of those patients, so 78% of those that had virologic rebound, were able to resuppress. And what they showed in this study really is that the time to virologic suppression to less than 200 was 41 days, and to less than 50, 58 days. I will note that there was no difference in time to virologic suppression from the time they started ART, even if it was delayed. So even if they waited and didn't start according to this rapid ART start, once people started their medications, there was no increased time to virologic suppression, if that makes sense. So for patients in San Francisco who are diagnosed, this has become somewhat the standard of care. This has not been necessarily adopted in most settings because of some of those barriers that I talked about. The HIV treatment guidelines that were updated this year and acknowledge these studies, but they don't actually fully endorse this. So they say that specifically that they acknowledge the South African and Haitian study and say that should not necessarily be extrapolated to the U.S. They acknowledge that the approach is resource intensive. The way they do it in San Francisco is very resource intensive. They have a whole rapid ART team of an on-call provider, nurses, social workers that essentially drop everything and do provide same-day ART for their patients. I will say that it's important to note that San Francisco has a unique insurance coverage system that allows them to get coverage for the ART right away, which may be different in some of our areas of practice. So the bottom line from the treatment guidelines is as these resources are not available everywhere and long-term clinical benefits of same-day ART initiation have yet to be proven in the U.S., this approach remains investigational. So I'm really excited to see that many of you are actually doing this and have been able to pull it off in terms of a resource perspective. I think it's wonderful that you are able to get people to get their meds on that first day. And I think it's hard to know how much of an impact from a health perspective it is to give meds on that same day versus waiting a few days, which is what we do at the Madison Clinic. David and I were talking about it, and I'm glad that Sandra's here because when providers rush into Sandra's office and say, we want to start meds same day because they're doing it in San Francisco, there's no reason we can't do it here, I think her head might explode. We need to appreciate that there's a significant amount of paperwork that goes in to be able to enroll people in insurance and to get coverage so that patients don't get a big bill for their care. And so unlike in San Francisco where they have this universal system for San Francisco where they're able to get coverage for people, I think we have to be mindful of that in other jurisdictions and really want to make a point of how much does waiting 1 day for them to come back or 2 days for them to come back make a difference. So I'm happy to hear people's opinions about this, and I would love to hear from the people that are doing it how they've been successful in doing this from a resource perspective.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.